Thanks everyone. It's so wonderful to be here, and as Rob noted, I've done some work with some of the scientists here, and there's some really fabulous stuff going on in this organization. So it's really great to be here to talk about a topic that I'm really, really passionate about, because with alternate level of care, there's a huge opportunity to learn from people who experience it directly to improve quality, based on what patients say, based on what caregivers say, based on what providers say, decision makers, all different levels of stakeholders. So just to get a sense of who's in the room, researchers, clinicians. Some people will be like multiple roles, managers, VPs, so a good mix. Is everyone familiar with the term alternate level of care?
No.
Yeah, no. So basically, alternate level of care, it's kind of a system label that we assign to patients when their clinical care is complete, but they're waiting to transition either to long-term care, back to their homes, or another setting like assisted living. But the reason why they're alternate level of care is because the next care setting that they need isn't available. And so what tends to happen is they're sort of stuck. They're stuck in limbo, they're in their hospital bed, sometimes unclear, uncertain when they're going to move on to their next destination. So not only is it expensive from an organization point of view, it's really, really confusing for patients and families and care providers as they figure out how can we work together to make sure that people are in the right place with the right mix of resources. So today what I'll do is provide a little more background information on what is alternate level of care, but also what do we know about this topic when we look at the literature. I'm going to focus on one specific case example. So I'm from Thunder Bay, Ontario, so a lot of my original research took place in northwestern Ontario, and I worked closely with the CCAC at the time to help them understand what was kind of driving their alternate level of care challenges, but from a patient caregiver point of view. So I'm going to share some of the work that we did there, but then, realizing after that it's not enough just to collect the story. So when we capture the story from patients and families, the next thing is how do we take that to actually work authentically with patients and families to start to develop strategies and to co-design changes and improvements, and then to implement it and test it over time. So personally, I'm kind of on this journey from capturing the story to then moving it towards looking at how we can change practice. And we've started to do that with more patients and caregivers across Ontario, including this hospital where we have a study going on right now. So I've already defined alternate level of care. So again, it's when a person has been medically cleared, usually by a physician, for discharge, but they're stuck in a hospital bed waiting for their next point of care. And sometimes it's clear where they're going. They might be in need of long-term care, so it's just a matter of getting further down the wait list to get into a bed, but sometimes it's really unclear where the person is going next. There might be conflict between family members in terms of the daughter might say, well, I think mom should go home, and the other daughter says, well, no, I think mom should go to long-term care. So sometimes it's not totally clear, and there needs to be a strategy around communication to figure out where to go next. So it's a point that's kind of a point of confusion, I think, for a lot of people. And to give you some statistics at a provincial level, the latest data show that about 16% of hospital beds across Ontario have people that have that ALC label. Within this LHIN, it's a little bit lower. It's sitting at 14%. But if you look at the northern LHINs, either the northeast or the northwest, 35% of hospital beds are occupied by people that are waiting to go elsewhere. And so the reason why this matters is because as people wait, the literature shows that they're at risk of functional decline, getting infectious disease or other types of falls risks, all the risks that you have by virtue of being in a hospital setting. Because during this time, care tends to drop or stop completely. So people are waiting, but they're not necessarily getting the activation and the restoration that they need during this time. And so there's lots of adverse outcomes that happen. And a colleague, Jason Sutherland, who works at UBC, he noted that it costs the Ontario government about $2.5 million per day. That's assuming that the hospital bed cost is about $1,000 a day. So you could argue that that's a fixed cost, that if those patients weren't in those beds, other patients would be in those beds. But if you start to calculate the costs of patients declining physically and mentally, opportunity costs for caregivers, you start to see that maybe those beds occupied by ALC patients isn't the best use, the best value for those dollars. And so looking at the literature, we've done a really good job at characterizing this population and understanding what are their physical, social, functional, demographic characteristics. We know less about the actual experience of people during this time. So older age, this is as dynamic as I get with my slides, so enjoy. Female, physical impairments, typically requiring assistive devices. These could be looked at as characteristics, but also as risk factors for ALC. Neurological disorders, cognitive impairments, aggressive behaviors, psychiatric diagnoses, multimorbidity, depression, social isolation, homelessness, in the US literature having a Medicaid status, lacking insurance coverage, and if a caregiver is available, usually they're quite stressed and have concerns over capacity. So as you can see, when you think about what the healthcare system has to offer, a lot of the times when people have any mix of these conditions, it becomes harder and harder to find the right place and the right mix of services to best meet the needs of this population. But, you can characterize people with ALC, but it's also predominantly a systems issue. So you can look at, some research has shown that you can improve the processes that happen within hospitals. So the timing of assessments, the way that teams come together to work together to have conversations, to talk about transitions, those can make a difference. There's assessment delays. A huge one is people would say there's a lack of long-term care beds or supportive housing units, but typically those that are culturally sensitive to the patient. So they might be waiting for a Chinese-specific facility, but there's a 3-year wait list. But the family doesn't want to send mom anywhere else. And you can understand the family's point of view, but then from, say, a clinician point of view or a manager point of view, you're thinking someone just had surgery, and we really need that bed for the person that has medically necessary needs. But this person doesn't want to go to a facility where no one speaks their language. So you can see all the tensions all the way along the way. Lack of available services on weekends, basically post-acute options, so continuing care, rehab, home care. And one that I haven't seen in the literature, but there's a lot of anecdotal evidence from what providers have told me in multiple care settings, the need for housing adaptations, but also a broader mix of housing options in general. So in the Northwest, there's about a 7-year wait list to get into a supportive housing unit. And supportive housing is interesting because it's this perfect mix of, you can have your own apartment unit, but you can hit a call bell and have someone respond to your needs. So there's lighter support services, lots of socialization available, but you still have that, residents will say they still feel that they're independent, they have their own space, they don't feel that they're not like a facility type setting. So a very recent systematic review which started to look at the experiences of patients, providers, and hospitals uncovered 35 studies in this area. And to the point of the last slides, it's consistent. They found that ALC is associated with mortality, reduced mobility, infections, depression, staff stress. So there's a lot of moral distress. For example, if it's a social worker that's working with the family and feels a lot of pressure to discharge someone, but they don't really know if they're discharging this person to the right place, but there's pressure from other parts of the organization to move this person along to the next setting. Extra bed days associated with canceled surgeries, treatment delays, and depending on how the costs are calculated, and I converted this to Canadian dollars, it could be anywhere from $350 to just under $1,000 per patient per day. Caregivers. So I know a few people are doing caregiver research. Any others? So family members, kind of unpaid. So basically, it's probably higher than this, but the latest stats that I could find says there's about 3 in 10 people provide unpaid support. This is a kind of an older stat, but equivalent to about $25 billion in unpaid labor per year. And the Donner report, which was out, I think a couple of years ago, noted that caregivers provide 7 hours of help for every 2 hours of professional care. So as soon as someone's typically in a home and community care setting, it's estimated that about 80% of care is provided by the family. And many people are providing care to their children at the same time that they're providing care to their parents, for example, so the sandwich generation. So if we know that a lot of home care is provided by families and informal sources of support. What about hospital care? So when I started the study, I thought, well, when someone's in hospital, the family probably gets a little bit of a break. Maybe they don't have to provide as much support. But we uncovered something very different when we looked at the data. And so after this, you can fall asleep, because this slide summarizes everything. You know when you find that magical quote? This is it. This kind of captures the essence of what we found. And this caregiver said she was just lying in bed for 3 days, a little 86-year-old. I wasn't very happy, but once I asked the questions, I wasn't angry, I wasn't upset, but once I asked the questions, I got the best services. The nurses were awesome, just nobody seemed to know what was gonna happen next. So a high degree of uncertainty from all the stakeholders that are involved. But the caregivers that are able and willing to advocate tend to get the results. But we also found that the caregivers that are going like, oh, it's not really my place, or I don't feel comfortable, I don't really know what my role is, could kind of see that they were at a disadvantage. So you can see that engagement has very different implications for, depending on the willingness to engage, will have different implications for people. So what we had done in the Northwest is conducted 18 one-to-one interviews with family caregivers of patients, and all of them were waiting for a long-term care facility placement. The length of stay ranged from less than a year to 3+ years in a hospital bed. Most of the caregivers lived separate from the patient, and because in the North, you have this phenomenon where even individuals like myself, I left Thunder Bay to find work in an urban center. So you have a lot of caregivers, in this case, that are living in another province even, and still trying to liaise and provide supports for their loved ones. But there's that separation, which creates a bit of a challenge when trying to mobilize care and support patients. So why do we do interviews? Can anyone relate to this? So before I spent time in Oxford, where I started to use narrative methods to uncover experiences, and that's where I met Susan. So that was great. I relied a lot on assessment data, closed-ended survey questions, and you can get like a big sample and a population level stock of data. But what I found was missing was the story, the context, like the nuances that really help you understand why things are the way they are. So I found I could really relate to the slide, and I find that sometimes when we're trying to assess, someone's experience, that they might not even be in the right state to really address that. So I'm going to talk a bit about this question of, could we prevent ALC? Could we do things differently before someone ends up in hospital? What are the missed opportunities in the community? What did caregivers observe while the patient was ALC? What did they do while the patient was ALC? And what caregivers wanted post-ALC? So what we had done with the interviews is just a standard thematic analysis with multiple reviewers. We compared notes and came up with some core categories of data to help explain some of these things here. Is ALC preventable? So it was interesting because we had everything from, and there was just one case where you had a 27-year-old construction worker falls off the roof and has a traumatic brain injury, and went to the hospital, had the best care on the brain injury unit, multidisciplinary, lots of attention from medical staff, from social workers. They did everything humanly possible to try to restore him, but he's at a point now where the family has to make a decision as to whether or not they're going to take him off life support. So at the time of the interview, they decided not to. A very spiritual family that was hoping that and said, this is in God's hands. But, when it was found that, we can't do any more rehabilitation, this person became ALC. So it's a very distinct case where it becomes a question about end-of-life preferences, working with the family to figure out next steps. But still, this person is waiting now to go to long-term care and is at the best place. We see a lot, I'd say the majority of the data would be this, the elderly couple, that they're just getting by, they're aging over time, getting increasingly frail, they have children that look after them from time to time, but then they have an accident. So they both, in this case, they both went down. The husband took the brunt of a fall, fractured his hip, and he was in hospital. There's a few delays getting the surgery. He ended up becoming ALC, had some infections, and had a little bit of delirium. He had dementia prior to, so that just started to get worse, and it was determined that he couldn't go home. But his wife went home, and she also has dementia. So when we interviewed caregivers for the husband, they're like, no, but he's fine. He's in the hospital now. We're going to get him into a long-term care facility. It's mom that we're worried about, because then we thought, oh, we didn't even know that there's another person in this picture. So we captured all this other context around there's so much going on in this caregiver's world about all the different people that they're looking after. And a really interesting case, and I think one that really hits on the social determinants of health, is this individual here, where over a period of time, socially isolated, she had illness very early on in her life and lived in social housing and really started to push people away. She didn't want any care services coming to her home, even though it was offered. She still had a fairly good relationship with her mom, but her mom, they still didn't really connect as much as her mom wanted them to, and eventually had a health event, ended up in hospital, and it was determined that she couldn't go home. But she says, she goes, I don't want to go to long-term care. Is there nowhere else for me to go? So you think of that, and there's lots of maybe missed opportunities, but more on the social determinant side of things. So some of these risk factors are really related to non-specific healthcare things. So it raises a question about who is, as a society, who's responsible to help get people off this particular trajectory. And so I hosted an event where we brought together patients, caregivers, providers, decision makers to talk about how do we best measure this phenomenon. And this care manager said, and in relation to the stories I just shared, we need to be collecting more information on who the patient was before they became ill. And this may help sensitize staff more when working with the patient and family. So rather than the patient with COPD, a patient with a previous work life history and a story. Because I think when we assess people when they come into hospital, we might say, okay, hip fracture. But there's so much more context around that hip fracture that could help us understand how do we work with this family to find the best place of care and the best way to proceed with treatments. And so getting to back to the caregiver categories about what's missing in the community, and we did, in addition to this, lots of engagement across the province of Ontario, and we found very similar categories in that people really wanted care that was flexible. So the timing of care, the type of services, a lot of people need supports with instrumental activities of daily living. So things like snow shoveling, housekeeping, meal preparation, and you could argue, well, that's not really healthcare, so who should pay for that? But if you targeted the people who would benefit most, so for example, the person that's at risk of falls, if you shoveled their driveway, they don't end up in hospital. So is there a way to target specifically to provide these lighter social supports? But you know, largely people wanted supports with these types of things. They wanted care that was reliable, so maybe one specific person or team that they could contact and get answers when they had questions and get supports when they needed it. Assessments to determine capacity. They found that some people that were providing assessments didn't necessarily have the same relationship that other providers had. So there's questions around who's the best person to do that. They talked about the need for consistent care providers, predictable services, but just having services available, so easy to access, and housing, retirement, homes, like those types of options for infrastructure. So to share some quotes, this is about determining capacity. So this caregiver who's looking after her great aunt said, the retirement home that took her didn't even realize that she was way worse off than they ever said she was. The woman couldn't walk, she was incontinent and needed 2 people care. And this was a woman that was at home by herself. And because of her dementia, she was saying, I'm mowing the lawn, I can do this, I can cook, and she had all these stories made up. And so, and this got me thinking about when an assessment is done, the role of the caregiver, you know, about providing that context to say, well, this is kind of my perspective on the issue, to really determine what's possible. But then, you know, the great aunt, if her, you know, dementia has not progressed too far, she could say, well, I don't want family members here for this assessment, and I can make these decisions. So you can see there's implications for how the information is collected and who's involved in this process. Another related quote, there's a lot of different things that are needed. Number one, if they want to look at keeping people at home, they've got to help out with caregiver burnout. If they're going to have a support worker come into a house, for them to actually work for 8 hours, cooking, cleaning, laundry, these kinds of things. So what did caregivers observe while their loved one was ALC? So they recognized that, you know, medical care was now complete, and they could see that providers and staff were really, really busy looking after people with heavy care needs. But they said, you know, they're still in a hospital bed, they still need support, so why is the person the patient's not looked after because they thought, well, it's no longer a patient, but the person is still there, and they still need some ambulation and activation and social activities, that sort of thing. And so they just noticed that this focus on acute needs over personal needs, they understood why, but it still had implications. The suboptimal process, so they found that things were communicated differently across different members of the care team. So they had some mixed messaging. Some people, to make room for a particular bed on a unit, people would move from unit to unit across the hospital. And that was particularly difficult for someone, say if they had dementia, they were confused, or the family member would show up and say, oh, well, mom's not in this room anymore, like no one told me. And so those types of things. Inconsistent care quality, so sometimes it was really, really good, or there's particular providers that people felt really connected to, but then it wasn't always the case with everyone. So there's lots of variation. I think that's a very common comment that comes from people when you assess their health experience, that, you know, there's always that one time that was either amazing or that one time where things just really fell apart, but it really sticks with them. And communication is a big one. So this caregiver said, you know, there's no regular toileting. She started off being fairly continent. She's not anymore. They seemed to be very pushy and getting him out of here. I guess they needed the beds or something. We didn't like the way it was going. They were suggesting that he come home. But there's a gray area where people are wanting to move around, be mobile, and so it's about this assessment of risk and how we find that balance. And even when someone, looking at the last quote, once they go back to the home and community, some providers will say, oh, they really wanted to go home and we didn't think it was safe, but it's about giving people the right to live at risk and have that choice. And I think it's a really interesting conversation to have, but it's also one that's a little bit uncomfortable when you think about the implications of going down these different roads. So what caregivers did while the patient was ALC, some were very heavily involved, filling in the gaps, doing things that the healthcare team wasn't able to do. A lot of it was help with meals, ambulation, those types of things. And there is, I'd say most of the caregivers we interviewed in this case were heavily advocating, trying to make things happen. But as I mentioned earlier, there were a few that just weren't, for whatever reason. I think sometimes it's generational, cultural, a number of factors, didn't feel that it was their place to advocate, but felt at a disadvantage. So this caregiver said, I'm here every day, 3 times a day, for breakfast, lunch, and supper to help my mom. The staff here are wonderful, but they're just overworked. They don't have the time to sit with each person that's on the floor to help them with their meals. My mom needs a little guidance every so often to make sure that she eats. And so this is a long one, so I'll just summarize it. But this is a scenario where patients talk about and caregivers talk about, it seems like ALC lasts forever. And then the bed becomes available and everything moves really fast. And so this caregiver's in BC. Mom's in Thunder Bay. She gets the call. They have to move mom to this long-term care facility bed before they lose the bed. But then mom has a hip fracture. She's waiting for surgery. They can't hold both beds. But the caregiver, being very savvy, working in the health system and knowing she can bend the rules, just went and moved all her stuff in anyway. She's like, well, we're good. We have the bed. But I'm not sure everyone would have the wherewithal to do that kind of move, because you can see that there's now 2 publicly funded spaces that are occupied. Right? So you can understand from a government standpoint why they'd want to have only 1 person per bed, but you can see the real dilemma here. And she's thinking, if we don't get this bed, mom's going to be stuck as an ALC patient even longer. So she took matters into her own hands. And so what caregivers wanted post-ALC, they talked about, you know, a lot of patients were in ward facilities, so they wanted to find a place, long-term care facility that had privacy, that was really tailored to their needs, but also in close proximity. I was thinking about, you know, if mom goes into long-term care, wouldn't it be wonderful if dad was in assisted living close by? So then he wouldn't have to drive and he would have that built-in social circle. Okay, so that was a lot of quotes, lots of information. So what are some of the things that kind of stand out from that? I had noted that there's some different trajectories into ALC and different types of caregivers that we interview, but key concerns were fairly common in terms of the uncertainty, the ongoing caregiver involvement, and the communication challenges. And as we started to analyze the data even from this hospital, as well as Health Sciences North, a lot of the themes that we're seeing kind of map onto these categories, this uncertainty, the communication, the involvement. And I think what's really interesting that perhaps we can discuss later is this tension between the role of the formal care, paid care provider, say in hospital, versus the role of the family, and how to determine what that balance is in terms of fairness and in terms of what will work in the health setting. And the ethical trade-offs, that whole, independence, safety dilemma that I noted, how to have conversations about that to determine the best way forward. And so our team, when we decided to go to other hospitals to unpack this, we thought, let's actually do a scoping review on patient and caregiver experiences in ALC, just to see, have we missed something? Is it consistent with what's out there? So Amanda Everall, who's one of our research associates, she did a scoping review, and we found 7 studies. Of course, it included the research I just presented as well. But you can see that what we're finding in the literature is fairly consistent with what I just presented. So things like people witness and experience a kind of mental and physical decline while they're ALC. There's a lack of engagement. People feel an impact from the variable care quality from staff, a lot of uncertainty, and a lot of kind of shock sometimes when people reach that ALC period, but then sometimes eventually accepting, okay, this is what has to happen next. And so in recognition that collecting the story can only get you so far, what we did is we secured funding from CIHR to then start to co-design strategies to address some of the problems that I just identified. And so this is the TC Lynn focused ALC patient and caregiver advisory group. We meet once a month, and I sat down with them and said, okay, you're gonna have to tell me how to do this. I'm a rookie because I usually collect stories, but how do we move the stories into changes? And so I spent some time getting to know everyone, where they talked about their own experiences as a caregiver or patient. Again, very consistent with some of the issues and the challenges that I just highlighted. And so I said to them, I said, now how can we take these stories, but put something together that's, we don't want to boil the ocean. We want to do something practical that we can test, maybe in some kind of rapid cycle evaluation eventually, and then make some small tweaks, because it's really easy to start to build this Cadillac model of care, and then everyone has high expectations, and then you go to try to implement, and everyone's going, what are you talking about? We can't do this. So keeping that in mind, we're looking at how can we make some small changes. So we put together terms of reference, as we typically do with these types of groups. And so there's basically 3 components, and we're just wrapping up this part of the study, but we have the council, which I just introduced to you. We did some research activities where we had focus groups with patients and caregivers, focus groups with providers, to try to see if we can hit on some similar care quality issues, which we did. And then with the support of Open Lab, we brought everyone together, and we actually started to co-design some strategies, which I'll share with you on the next slide. But I think the critical piece is also to how to package what we're finding for audiences like Ontario health teams. Developing strategy documents, working with hospitals to say, this is what we found, how can we tailor this for this particular context? And so we have some funding from the Ontario Sport Support Unit to actually bring these findings here, as well as the Northeast, and to bring in patients and caregivers with ALC experience to say, this is what we found in Toronto, recognizing this is not Toronto, and Sudbury is definitely not Toronto. So does this resonate, what's being proposed, and how do we tailor it for this local context? And so when we did the mapping and the focus groups, we really wanted to capture people's feelings. And I got super pumped about this Wordle, because apparently this is old hat compared to the advisory group. They told me that this is an old way to present data, but I was excited. But to no surprise, stress, frustration, so the things we nerd out about, right? This is largely how they felt in their experience, which wasn't a huge surprise. But there's hope, there's positive emotions in here too that need to be paid attention to. When we said, patients and caregivers, if we give you a magic wand, what would you change? And they said, you know what? We know that care is not going to be perfect, and we know we might not get what we want, but we just want everyone just to be honest. Even if you don't know, tell us you don't know. I thought, okay. And they said delivering messages with empathy and compassion, but also the tailoring for people with dementia, non-English. There's someone who is visibly impaired on our council, and he said, tailor it for someone like me. I can't see anything, but talk to me so I can understand, what's happening. They also talked about, because we had a lot of caregivers involved in this, naturally, and not surprisingly, they said, they want more support, they want to be acknowledged, they want to be part of the decision-making process. Providers would challenge me on that and say sometimes they try really hard to bring caregivers into the discussion and they're not available. So, we have a very engaged group of caregivers here that are, and that's one segment, but there's also a lot of family that might not be as involved. And patients and caregivers talked about this whole dilemma of the long wait, and then everything happens really fast. So they said, how can we manage expectations during that very uncertain but then very rapidly changing time to make it work better? So they talked about that. When we talked to providers and said, now if you had a magic wand, what would you want? They, I'd say, mostly focused on things that are outside of hospital. So they're spending a lot of time, obviously, discharge planning, trying to figure out where people can go next. And they said, we need more assisted living, supportive housing. You know, there's great programs out there, but they're few and far between. And if we could, you know, build, instead of just building long-term care facility beds, thinking about long-term care in terms of spaces more broadly, then they thought, we think we could support more people during that transition. They talked about a really interesting policy change that I'd like to get people's feedback on. So apparently, I don't know if this is a hard-grained policy or a practice, but in British Columbia, in any hospital, when it's determined that someone's ALC, they immediately go to the first available long-term care bed. Is that right, Rob? And then they wait from that bed. So it doesn't matter where in the province it is or in the region, they would go there, and that immediately has, you know, the space available for someone that needs hospital care. But I'm not sure how that would fly with different stakeholders. But a lot of the providers were very keen on this could be a way to free up, to make sure people at least get into a place that's maybe a little bit more suited to their needs. They talked about, similar to patients, better communication. They said we don't really know sometimes how to have that conversation about ALC. It's kind of a process where you're realizing over time that someone's not responding to treatment anymore. We're going to have a conversation soon about next steps. But in that time, care might stop or feel different for patients and families. They don't really know why. And in talking to social workers, sometimes they feel the buck kind of stops at them. They're busy doing the transition planning and having less time to sit with patients and families to talk about next steps. And they also talked about the need, greater respect and options for people with behavioral challenges, and providers said sometimes they feel there's an assumption as soon as there's dementia or behavioral challenges that it's just long-term care and there's no other options. And so in the co-design session, to map on to things that were important to patients, families, and caregivers, we had a station where we talked about how do you have the initial conversation. We talked about questions that should be asked back and forth during the ALC phase, but also, and the advisory group felt really strongly about this in determining what a basic minimal basket of services would look like during that period. And so this was interesting. So we had a nurse educator who talked about principles in palliative care. And she said, when you're initially having that conversation to a patient or a family, recognizing, you know, that's a vulnerable time, she said, assess the person's understanding of their illness. Instead of jumping into, we think this is the next way to go, this is what you should focus on. So it was a really interesting kind of switch in how she felt the conversation should occur. And asking, you know, what have the last few months been like? What are you hoping will happen? And then being really clear about, you know, your medical care is done, and we're now looking at next steps. And so in cases where patients did not meet predetermined goals or have plateaued, it's about being honest and being okay with the disappointment that I think all members of the care team will feel, to say, you know, we're disappointed too. We were really hoping that this could happen, and we want to do everything we can to try to make sure it's, you know, you get to a place that's going to work for you. But kind of owning that, and everyone being a bit vulnerable together, which it could be really awkward and it's hard, and that requires time and relationships and letting your guard down, but having the space to really share and talk about goals. And all providers I talked to, some are doing this really, really well. Others struggling to do it well and talk about they want to do it, but how, when, where, you know, there's lots of questions around that. Questions during ALC about long-term care, you know, really tailoring the choices based on knowing the people and the families in terms of what might work for them. Assessing social network, and in the absence of a social network, perhaps assigning a volunteer to an ALC patient that could be their advocate. Expectation management was huge. To be really upfront to say the volume of care is going to change drastically. It's going to drop a lot. It's not going to be the same as it was when you were a full-time acute or rehab patient. And to say things are going to be really uncertain. And we're going to keep updating you, but it's really confusing time for all of us as we try to find the next steps that are going to work. And owning that the course might change. You know, and a patient said, he goes, well, what if someone said, you know, we have kind of 3 different options, and we have kind of the the option that we're all aiming for, but we might have to shift course and try option B or try option C, and kind of preparing people for the fact that it might not go according to plan. For baskets of services, so this is like all the kind of strategy people in the audience. I was trying to do a, what would you call this? What is it called? Like a flow chart, or I don't know, there's a fancy name for it, but yeah, and I was trying to think, okay, so what's the aim? And then what are all the different components that could then feed into that? So this is my very kind of sad looking, very text-dense way of looking at that. So when people talked about basket of services, they said things like physical stimulation, mental and social stimulation, life course, logistics. So these are the kind of the minimal things that could be happening during ALC. And then they talked about the enablers to that. So if you assigned a provider to, for every ALC patient, a dedicated time to take them out of their bed at a specific time. It might happen, it might not happen. So they said if that was like a standard of practice. I also read a Globe and Mail article about what would it be like if patients wore regular clothes and it got out of their gowns. And so it's kind of that idea of getting people up and mobile and moving around and feeling like a human, feeling like they have purpose. Group exercises, community day programs. For the mental and social stimulation, Holland Bloorview has a storyboard. I don't know if they use that here, but basically it's a way to get to know all the patients, just how they pronounce their name, what they prefer, particularly with dementia, this is really important. Interests, social interests, pet and music therapy. And in terms of logistics, finding and making an appointment with their GP, managing prescriptions, really getting things in place for the next setting of care that they have. And to me, I'm looking at this and I think it kind of feels like long-term care. You know, like these are the types of things that would happen. But then I thought, how would you enable this in a way that is doable cost-wise? You know, and they talked about leveraging the volunteer sector, getting trainees in that do like arts-based therapy, you know, people training to be social workers, training to be physios, and it's sort of a win-win where you can start to build capacity for training, but also meet the needs of people that are waiting for their next point of care. So next steps is to package these co-design strategies in a way that we could then feed it back to patients and caregivers here, as well as in the Northeast, and get their sense on how do we tailor that for their needs. We're going to continue to capture the ALC experiences of patients, caregivers, providers, managers, and decision makers to round out our understanding of experience in this LHIN and the Northeast. We also have funding to look at international best practices related to care transitions and alternate level of care, and also looking at the local leading practices that don't tend to get published. But what are the things that, like even in this hospital, what are the things that are working really, really well that we need to understand so we can start to do more of it, to replicate it, to understand what are the key ingredients. So we'll be doing some interviews to understand what are those kind of local best practices. And also, finally, taking some of these strategies and starting to test them in continuous improvement cycles, leading more towards a full-scale evaluation. So if we start to implement these changes, what does it mean for the experiences of patients and families? What does it mean for cost, quality of care, different types of outcomes? So I think there's a lot of opportunities to really push this a lot further. So the goal is to really position this work for systems change. And I know Rob Reed's done tons of work in learning health systems, one of the thought leaders here, but I think there's an opportunity to start to take this information, work closely with clinical teams to get their feedback and try to figure out ways to tweak and to work together and measure and see if we can slowly start to shift and make a difference for these particular patients. And any policy wonks in the audience? Multiple streams. So when do ideas get taken up? Even when do research ideas get taken up? Is when everyone agrees that something's a problem. So we'd all agree that hallway medicine, delayed discharge, you know, poor quality patient care, people would agree those are issues. There's also proposals to deal with the issues. So we could build more long-term care beds, we can build more supportive housing units, we could change and adapt how we, you know, our hospital processes. But there's also politics. We have a Premier's Council that aims to end hallway medicine and better integrate care. We have Ontario health teams that are popping up that want patient and caregiver engagement and experience to be at the center. And I think hospitals are going to be the hub for this work. So you can see how all these streams coming together, we have an opportune time to position this type of work and deliver it in a way that we can start to implement and hopefully make some changes. So we have a policy window here. But that's my spiel. But I'd like to thank the people who have funded the work, largely the Ministry of Health and Long-Term Care. That was the caregiver ALC work. But then the co-design piece was really the Ontario Spore Support Unit, along with the CIHR Spore that supported that. So we have our advisory group members, research team members, and funders. So thank you very much.